good evening, everyone. It's lovely to have everybody on board. Thank you very much for joining the MR Safety Week 2025 presentation with us, who are the Professional Alliance of Indian Radiographers, who are closely associated with the Society and College of Radiographers. A very warm welcome to you all, and thank you for joining us tonight as we mark a very important occasion, like I've just mentioned, which is the MRI Safety Week. So this event is proudly hosted by the Professional Alliance of Indian Radiographers, and I am delighted to be your host today. My name is Afra Sulfikher. I currently work as the Radiology Service Lead for CT at United Lincolnshire Teaching Hospitals NHS Trust. I'm also honoured to be the chairperson for the Women's Wing at Professional Alliance of Indian Radiographers. For those of you who aren't aware, let me give you a bit of a background on the birth story of this very special week in the world of radiography. So, MR Safety Week is observed internationally to raise awareness about safety in magnetic resonance imaging and to honor the memory of Michael Columbini, whose tragic death in 2001 served as a wake-up call to the global imaging community. Since then, MR safety protocols have evolved significantly, but with rapid advances in imaging technology, the rise in patients with implants and increasing scan volumes, MRI safety continues to require our full attention. Recent studies have shown that while we have reduced catastrophic incidents in MRI, burns and implant-related complications are unfortunately on the rise, which often due to insufficient screening or knowledge gaps or even workflow pressures. So that's the very reason why events like these are so important in order to refresh our understanding and learn from those leading the way in safe practice. So tonight we are bringing together our highly respected experts in the field who will explore different facets of MRI safety, ranging from hardware and infrastructure to patient screening and implant safety. All right, so I've just put my presentation on, which means I cannot see anybody in the background. So we're just going to straight away smash through our speakers. And if anybody have any questions, please may I request that you write it down somewhere, because we are going to have a quick question and answer session at the end of this event. So please bear with us while we get all of that valuable information we have through our expert speakers lined up for today. So to begin our session, we are joined by Shilpa Singh. Shilpa is a clinical scientist at University Hospitals Coventry and Warwickshire NHS Trust with over 16 years of experience in medical imaging and radiology safety. She holds a master's in medical physics and a bachelor's in radiography. Shilpa has served as assistant professor, radiographer, and radiation safety officer, and she has also authored over 30 peer-reviewed publications and contributed to academic textbooks. Her research focuses on MR, CT quality control, radiation protection, and patient safety. She actively participates in international workshops and certifications, promoting excellence in radiology science and education. Shilpa is a passionate advocate for continuous learning and healthcare quality improvement. Shilpa, thank you very much for joining us today. The stage is yours. Feel free to share your screen, Shilpa.
Thank you. Am I audible?
Yeah, we can all hear you
Perfect.
now. Yeah.
Okay. So thank you so much, Afra, for your kind introduction. And I'm really very honored to be here today. I'm thrilled to talk about the about the hazards in the MRI, and which is a subject which I deeply am passionate about. Over the next 20 minutes, we'll be exploring the hazards which are related to the components in the MRI.
Did you want to share your screen?
Yes, I do.
Yeah. All right, thank you.
Should. Here it goes, live. Perfect. So is that visible?
Yeah, that's fabulous. Thank you. If you want to put it on slideshow, so. Just hover over the slideshow option.
Yeah, I'll try to.
Thank you.
Perfect. Is it visible?
Yeah, we can all see that. We can all see
Thank you
your
so much.
PowerPoint.
So,
Did you want to put it on a show at all, Shilpa? Or are
is
you
it
happy
not?
this way?
Okay, so I thought it's visible as show. I'll connect it again.
Yeah.
Should work now.
Yep. Ah, there you go.
Visible?
Yep,
Thank
that's
you.
perfect. Thank you.
Okay, thank you. So I will be discussing about the MRI components in detail and how these components are related to the hazards in MRI. We will be discussing about the magnet, main magnetic field, the gradient field, the RF core. Apart from this, we will not be discussing anything in my talk. So basically, these hazards depend on classification on the magnetic field. There is one which is called static magnetic field, which does not change with time or with direction. Other one is called varying magnetic field. This varying magnetic field does change with the direction and or time. So static magnetic field is the main magnetic field which we insert the patient in. Varying magnetic field is number one, gradient field, which changes from time to time as we use different pulse sequences. And radio frequency, when we want to apply the RF pulses and we want to collect the signal, we use radio frequency. These two are both varying magnetic field. Main magnets. Nowadays, we mainly use the electromagnets, either superconducting magnets or the resistive magnet. They both are essentially the electromagnets, a kind of solenoid, which is immersed in cryogens. Cryogens means liquefied helium. Then this liquefied helium is filled in the tank and we use this shim coil either inside, as you see here, or outside the main magnetic field. Means electromagnetic field can be inside or can be outside the shimming coils. Why? I'll discuss about that later. For now, we will discuss about the main magnets. So the main magnet hazards are classified into physical and biological. Physical include projectile effect, implants. Projectile effects usually we all are aware about. Projectile effect can be because of any metal or any magnetic substance which has been taken into the scan room, zone 4, or I should say, according to the UK classification, MR environmental. MR environmental room or zone is the zone where the MRI scanner is placed, excluding the other areas which are MR compatible areas. If we take anything which is magnetic or metallic into the scan room, it can turn into a missile and can be attracted very strongly towards the center of the magnet, that is the bore, and whatever comes in the center or comes in the way can be damaged. Implants. They can be displaced if we place them inside the main magnetic field or if they are driven by electricity or magnetism, they may start malfunctioning. Spinal cord stimulators or vagus nerve stimulators can be damaged or can be overheated when placed inside the main magnetic field. So they are very dangerous and they turn into a hazard when they are taken into the MRI scan room. Biological effects are cell membrane permeability. Up to 2 Tesla magnet, which we usually use like 1.5 mainly, sometimes 3 Tesla. It doesn't cause any change in the cell membrane permeability in the humans. However, the studies have been done on mouse, and it shows when we expose the mouse at 4 Tesla magnet, the cell membrane permeability increases. It increases means there are chances that blood-brain barrier can be damaged. But it happens at very high magnetic field, so we don't need to worry about it. Then Nausea, vertigo, or high BP are also observed in patients who have undergone MRI on 4 Tesla magnet. However, up to 2 Tesla, there are no such biological hazards observed on the patient. And that's why we use 1.5 or 3 Tesla magnet very freely. Cryogens, those are helium plus nitrogen. I'll tell you about nitrogen later. Helium, as I said in the previous slide, that helium is used at very low temperature. As you can see, it's 20 degree Kelvin. Because if we won't use the helium, it would heat up and the electricity would not be able to convert into the magnetism. And we want to save the electricity, so we immerse this electromagnet into the liquid helium. It absorbs the heat, allowing the electricity to continuously flow through the magnet, maintaining the magnetic field. But liquid helium also absorbs energy or heat. It converts into gaseous form. When it converts into gaseous form, it can be fatal. So that's why this helium is immersed in turn in the liquid nitrogen. Why they chose liquid nitrogen? Because liquid helium is a heavy gas. Number two, it's very expensive. And we need almost 1,100 liters of helium for one MRI scanner for 1.5 Tesla magnet. And we immerse this tank in turn into the nitrogen tank so that nitrogen is not as expensive as helium. So it saves the cost. And as the helium starts turning to gaseous helium, the liquid nitrogen cools down the helium in turn. And so the helium is maintained. As such, helium and nitrogen are not directly in contact with the patient, but in case something goes wrong, they are very, very, very cold, minus 259 degrees Celsius. They have the capacity to burn the human flesh. Other thing is quenching. I'm sure you all are aware about the quenching. Quenching is nothing but conversion of liquid helium into the gaseous helium. If it happens accidentally in the MRI scan room, if the patient is in, or if there is any other staff member or any other human inside, it can cause possible asphyxiation because liquid helium, being a heavy gas, replaces all the oxygen from the room. The patient won't be able to breathe in the oxygen and thus he can die of asphyxiation or frostbite, lack of oxygen in the body. Now I'll talk about shimming. So in the previous slides, I showed you two shimmings. One was inside the electromagnet, one was outside the electromagnet. Why it happens? Because there are two classifications of shimming. One, active shimming. Number two, passive shimming. Active shimming is nothing but again a kind of solenoid or multiple loops of current carrying cable which reinforce their own magnetic field onto the main magnetic field, providing a better homogeneity of the MRI scanner. If you place them inside, they are more efficient. But now they chose it to be placed outside. Why? Because when we have an MRI scanner, we have some space constriction. If we want to install an MRI scanner, we have to be very careful about the fringe field, the magnetic field which extends outside the MRI scanner. If we place the shimming coils outside the MRI electromagnets, it not only helps us improve the homogeneity of the MRI, but also it limits the fringe field. So that's beneficial. It can be placed inside or as well as outside, but we choose one. On the other hand, passive shimming is nothing but very tiny pieces of ferromagnetic substances placed inside the electromagnetic bore, placed inside at different intervals. So as you can see here, this is the real MRI scanner opened up, and you can see small pieces of ferromagnetic substances placed at equal distance. But they do not require any magnetic field or electric field to be circulated through them. They are ferromagnetic, so they will use the electromagnets to be magnetized. In turn, they create magnetic field which is as strong as the main magnetic field. But if something comes in close contact or inside the scan room, which can change or alter the magnetic field homogeneity, they will make sure that they can convert it back to homogeneous. They do not require any power supply. So overall, I think you have understood that shimming is nothing but the same main magnetic field. So I can say that it's stable magnetic field. And so there are no hazards which are associated with the shimming. Gradient coils. We all know there are three sets of gradient coils which have magnetic field which varies from one direction to other. If you talk about the z-axis coil first, the slide selection axis, we have two coils, one at each end of the bore, and they increase the magnetic field from one end of the bore to the other. Similarly, we have two set of saddle-shaped coils, X and Y, which are placed in perpendicular direction, which are used for phase encoding and frequency encoding interchangeably. The hazards are again divided into physical and biological. So we'll start with physical effects. Metallic implants can be displaced or may start malfunctioning because this is again magnetic field which changes from time to time. Heating of tissue around the implants, even if the implant is MR non-compatible, if it is brought inside, it will cause the tissue surrounding the implant to heat up. When we listen to the vibration in the MRI room, that is essentially because of the gradient coils. What is missing here is the acoustic noise. We all know that when the gradients are changed, they create very heavy noise. So that sound which we hear during the MRI scanner is all because of the gradients being changed, switch on and switch off. Biological effects include, this is called magnetophosphine. The person who is undergoing MRI can see flashes of light. Mostly the patients have observed white color light, but some also say that it was yellow or blue. But it occurs only if the gradient changes very steeply. Very steeply means more than 20 Tesla per second. It occurs when the patient is experiencing the gradient magnetic field plus there is motion of head or eyes perpendicular to the gradient direction. Otherwise, he would not observe any flashes of light. Then next comes the peripheral nerve stimulation. Peripheral nerve stimulation or tingling sensation is also observed by patients when we switch on and off the gradient fields. The nerve can be stimulated. Eddy currents. Eddy currents are some extra currents which can be included into the patient's body. They are induced because it forms a loop inside the patient body. What is that? So I'll show you an example. If you see the patient's hand is kept in the waist and it converts the patient's body part, converting into loop, and this loop allows the eddy current to be flown into the body. Of course, it's not good. Whichever body part is touched and converted into loop can heat up to the extent of burn. So you can see both the legs seem to be burned. That is why we have the non-conductive foam pads available in MRI, which are to be placed in the patient between the arms, between the legs. And there should be no loop formation which should allow the current to be flowed. No legs crossing, no holding hands, no hand touching the waist or any other part of body. Also, if you see carefully, the patient also has been given the non-conductive pads next to the MRI bore. Why? We will see that later. We should also be careful when the patient is introduced to the magnetic field, he or she should not be wearing accessories. There should be no metal component in the clothing at all. Then next comes the radio frequency coils. We all know radio frequency coils are divided into volume coils, phase array coils, quadrature coils, or surface coils. The hazards are again classified into physical and biological. Now, the hazards would depend upon the radio frequency coil in a pattern which is similar to the gradient. First thing is SAR, specific absorption rate. What is specific absorption rate? When the patient is being given the radio frequency, which is a very strong electromagnetic field, and the RF coil is placed very close to the patient, the energy is converted into heat. If this heat deposited into body tissue becomes high, it can cause damage. But we don't have to face that. Why? I'll tell you. There are SAR limits already fixed. So if there is any particular organ and the heat goes above 1 watt per kilogram of body weight, MRI scanner is smart enough to detect that, and it would pause the scan immediately until the patient's tissue has cooled down below the safe levels. We cannot proceed the scan. So we need not worry much about the SAR. But yeah, there are certain limits that we should be giving the maximum SAR to the body, head, or per kilogram of body weight. Heating of tissue around the tattoos and metallic belongings, similar to as we have seen in the gradient coils. Because again, it changes with time, and also the tissue, the tattoos have very small, tiny microscopic metallic component or the metal belongings. I'll show you some very beautiful examples later on. The metallic belongings may not be necessarily the jewelry or the rings or something which we are obvious about. It can be something which we may not even notice in our day-to-day life, but it can cause damage, and the damage can be as severe as burn. Biological effects. During the RF, cardiac output increases, blood flow increases. The patient can again observe magnetophosphenes. This magnetophosphenes is different from the other one in the gradient magnetic field. Gradient magnetic field was stable in one direction. Here the RF pulse changes on its own. So in this case, even if the patient says, no, I did not move my head or my eyes, he may feel the flashes of light, because here the patient is not moving, but the energy is moving. The magnetic field is moving with time, which can induce the flashes of light. Metallic taste. The patient may complain of taste in metal taste in his mouth because the taste buds are stimulated. So here I have some examples. As you can see, this is called as antenna effect. There is a pulse oximeter which was hidden, and this burn has gone so severe that it has turned to third-degree burn. Another thing, conductive burn from abdomen pressing against the bore of magnet. Pressing against the bore of magnet, that is why there were non-conductive foam pads placed between the patient and the bore. This is called proximity burn. I'll show you a very interesting example. There was a case report very recently in Japan that the patient was wearing the joggers. There was nothing, obviously, there was nothing magnetic into the patient's body apart from the clothes. Immediately after the MRI scan was over, the patient complained of very heavy pain or burning sensation along his thighs. The patient was sent home. It's just not very obvious, but 1 week later, there were severe burns on the skin along a line. It was later checked using the lowers, the joggers, high resolution digital imaging, digital X-ray was performed, and in the digital X-ray was realized that there was micrometallic component in the stitching of the trousers, which we are not very sure of. So that was it. This is proximity burning. Whenever we have MRI bore very close to the patient's body, when we apply the RF energy to the patient, it heats up. The closer to the magnetic bore, the more the energy, because we don't have only one RF coil. We have two RF coils. I'm sure you all are aware. There is one inbuilt RF coil in the body, in the MRI bore, that is called as quadrature coil. And there is a separate, specifically designed RF coil which we place over the magnet. The quadrature coils usually are essentially the transmit only coils. The other one, which is in close contact with the patient, is both transmit and receive only coils. So the closer it is to the patient, the more are the chances of the proximity burning. That is why we need those conductive pads on both sides of the patient's body if it is very close to the bore. If you see the image carefully, you would see the area surrounding this tattoo has turned red. Obviously, it did not cause any burn so far, but you can see this is nothing but just the socks, which are called compression socks. They have metallic microfibers. Just imagine they have the microfibers which have metal in it into such small extent that they could only cause the artifact. If this metal component was slightly higher, it could have caused burn. With this, I finish my presentation and I'm really grateful to you all for being such a nice audience. I will pass now to Afra. Thank you.
Wow, Shilpa, that was an excellent and technically rich overview. Thank you so much for that. You basically reminded us that MR safety starts long before the patient actually enters the room, isn't it? It begins with the design, the configuration, the maintenance of the scanner environment itself, actually. I think as radiographers who are so used to working in busy environments, we often tend to see our scanners like conveyor belts, and we often overlook the emphasis of the role of shielding and RF cage integrity, and also the risks associated with improperly maintained hardware or coil connectors, don't we? So, the importance of working closely with clinical scientists and engineers to address small faults before they lead to major incidents in MI is really, really important. You've just said that, shown that to us, basically. Thank you. Again, a timely reminder that our collaboration with physics and engineering teams are absolutely central for a safe MR service. Thank you very much, Shilpa. So again, to all of the attendees here, can I just remind you to please save your questions for the end of the session. We are going to have a couple of minutes for a proper discussion and interactive session amongst all of us. So before we lose any more time, I'm just going to try and share my screen as we welcome our next speaker. Abhilash. So Abhilash Thachandra Rajan. Abhilash has 5 years of experience as an MR application specialist in Philips Electronics India, and he's specializing in advanced neuro MRI applications like functional MRI, multi-nuclear spectroscopy, and DTI, along with other routine MR applications. For 6 years, he has worked as a senior MR radiographer in Parkside Hospital, Wimbledon, and he's currently working as a lead MR radiographer in Cleveland Clinic London since 2021. Abhilash, over to you. Good luck.
Thank you, Afra, for your kind words. I would like to thank Team Pair to invite me to this presentation. And I'll start my presentation with its basics of MR safety. And also I'd like to touch with the safety aspects of the intraoperative MRI or IMRI as well. Sharing my screen. Am I audible?
Yes, you are, Abhilash. Yes. Just waiting for you to put it on your slideshow.
My screen is visible, right?
Yeah, your screen is absolutely visible. No problem at all.
MRI is designed to provide clinicians with the versatile diagnostic imaging and treatment planning capabilities.
Yeah, sorry, Abhilash, just one moment. I'm just going to interrupt. Sorry about that. Did you want to put it in a slideshow so it's much more clearer for everyone, if that's okay?
Yeah, sure.
Yeah, thank you.
Thank you. And it's a very powerful technology, but its operator or personnel working in this environment should be aware of the associated safety hazards, and they should know how to reduce these risks. This is a diagram of a typical MRI department. So the whole MRI department is divided into multiple zones. It's zone 1, zone 2, 3, and 4. Here in UK, we say transitional area, MR control access area, and MR environment. Zone 1 is a freely accessible area for general public. This is outside the MRI department. And Zone 2 is a transitional area between the more restricted areas like Zone 3 and 4 to Zone 1, which is more accessible for the general public. In Zone 2, patients will be received, this reception will be included in this area, patient will be changing and they will be prepared for the MRI examination. Zone 3 is the area also called as controlled access area. This is the area where the radiographer sits, the MR control room included in this area, and also the areas just outside the MR environment or Zone 4. And this is a restricted access area. Only the MR personnel or authorized person will be providing the access to the other people after screening. MR Zone 4 is MR environment where the magnet sits. And this is more restricted access area. And this will be under the observation of MR person. Outside the Zone 4 or the outside the MR examination room, you can see the first warning sign, which includes magnet is always on, pacemakers like implants are not allowed without checking, and no access for the unauthorized public. And also we are mentioning about the hearing protection in this. And outside the MR control access area, we can see this signboard. What is MR safe? Any item that does not pose any hazards in the MR environment, which includes non-magnetic, non-metallic, or non-conductive materials. MR conditional, similar to the MR safe items, there are conditions for these MR conditional items. Those conditions related to field strength, spatial gradient, time varying magnetic field, or the gradient field, radio frequency fields or the RF fields, and specific absorption rate. MR unsafe items. These items are not allowed inside the MR environment. Mostly they will be ferromagnetic materials. They will be denoted by this symbol. And also in the MR control access area, any items kept in that area or in the MR environment should be labeled according to MHRA. Acoustic noise. This is the noise occurs when we pass current through the gradient coils. And MRI can produce acoustic noise levels from 80 dB to 130 dB. Depends on the different pulse sequences used. And this can cause hearing damage. It could be temporary damage or a permanent damage above 140 decibels if you have prolonged listening to this particular noise. We have to provide the hearing protection aids to the patients, which includes earplugs and headphones. Earplugs are mandatory for the patients as well as those who are staying, like the carers or any staff members staying with the patient. And with the use of the earplugs or any hearing protection aids, the decibel level should come down to 99 decibel, which is a permissible level. MR manufacturers also trying their level best to bring this acoustic noise down. They're using the gradient enclosures, which means enclosing the gradients in vacuum chambers to dampen the vibrations. And they're also improving the gradient coil binding using some resins and low noise imaging software, which includes the development of the sequences with the gentler waveforms of the gradient and also longer ramp up and ramp down time, which includes the soft tone sequences, quiet suits sequences, etc. SAR or specific absorption rate. Shilpa has already explained about SAR. I would like to touch base with this. In a normal operating, SAR limit is 2 watt per kilogram. And in the controlled access mode, it can go up to 4 watt per kilogram. This is for the whole body SAR. And for the head, it is 3.2 watt per kilogram, regardless of the operating mode. We should know how to reduce the SAR while we are scanning a patient. We can take breaks between high SAR sequences, and we can also alternate the low SAR and high SAR sequences that will reduce the SAR. And also the main thing we have to remember is to dissipate the heat. So if you are putting more and more blankets on the patient, so the heat dissipation will be less and the SAR levels will go high. We have to reduce the flip angle if the SAR is going high in a sequence, and also reduce the number of slices. In case of RF pulses, we have to reduce the number of RF pulses. I mean, the TSC, in a TSC sequences, we can reduce the number of flip 190 degree RF fluctuations, and also the duration and the frequency of this pulse. And we have to make sure that the patient is lightly dressed for the scan. And we have to increase the ventilation in the scanner room by turning on the fan inside the bore. And coming to the radio frequency effects of the um, specific hazards in the MRI field, heat stress can be a problem, and it will be more prominent for a patient with hypertension, those who are pregnant patients, and those who are having medications like diuretic, vasodilators, etc. The near field effect or the proximity burns, this is because the patient's hands or arms are touching the bore of the magnet. This is more prominent for obese patients. And we have to place the spacers, 1 to 2 centimeters cushions between the patient and the bore of the magnet. And the 1 centimeter area just inside the bore of the magnet, it's called danger zone. So there is a strong chance of heating up if you keep the body part in that area. So that's what the spacers are avoiding, and that avoids the proximity burns. And I would like to mention about the resonance circuitry effect of the RF as well. We always discuss that when we go from the lower magnetic field to higher magnetic field, all the SARs, HASARs, everything goes high. There is one component which will be more prominent on a low strength magnet in comparison with the high strength magnet. This is due to the leads present inside the patient's body, which are insulated. In case of any insulated lead, the heat dissipation will be very minimal, and both ends of this lead will be touching the patient's skin or patient's body. It will be implanted inside as well. And if it is in the x-axis, I mean the head to feet direction of the patient, and if it is in this particular length, for a 3 Tesla scanner, it's 12 centimeter. For a 1.5 Tesla scanner, it's 25 centimeter, and a 1 Tesla scanner, it will be 36 centimeter. This is calculated as per the resonance frequency of the particular scanner. For 3 Tesla, it's 128, and then the half of the wavelength will be approximately 12 centimeter. And this is calculated accordingly. So when we move from 3 Tesla scanner to a 7 Tesla scanner, what will happen? This 12 centimeter will come down to 5 or 6 centimeters. Most of our implants are within that range. So there will be drastic increase of RF related, especially the resonance circuitry burns when we move from 3 Tesla to a high strength like a 7 Tesla magnet. Pregnancy and MR exposure. There are no clear evidence that the exposure to static or static magnetic field can cause adverse reaction, adverse effect on the pregnancy outcome. But as a precaution, MRI scan is not permitted in the first trimester of pregnancy. And MHRA recommends that pregnant patients should be scanned only in the normal mode. They should not be scanned in the first level mode. If you decide to scan them in the first level mode, that decision should be based on the risk benefit assessment with the clinician, radiologist, and the patient. And also MHRA recommends that the pregnant staff member should not stay in the MRI room whilst operating or the gradient field is on. And this is also to avoid the acoustic noise and its effects on the fetus. Emergency quench. Shilpa has already explained about quench. Quench is the rapid release of the cryogens, and it results in the loss of significant decrease in the magnetic field. And a quench should only be performed by an authorized personnel in case of emergency, which is life-threatening situation or which is causing serious injury to a person. The worry about the quench is potential asphyxiation and the frostbite. As we know that helium is lighter than oxygen. So if the quench pipe or the vent pipe is not functioning properly, there is a strong chance that the helium can leak into the examination room and it can displace the oxygen. So the helium will be on top layer and oxygen will be down. So that can cause asphyxiation. And also the temperature of liquid helium can cause the frostbite. And also, as we know that inside the MRI chamber, there are like 1,100 to 1,400 liter of helium, and helium is very expensive. And also during this quenching, we had to de-ice the helium chamber, and also we had to bring this magnet back. So that will cost a lot of money as well as the downtime, and we won't be able to scan any patients during that time. And there are quench buttons and emergency power off buttons present in the scanner room as well as in the technical room, not technical room, the control control room. And the top one is emergency power off button. It doesn't quench the magnet, but this can be used in case of fire, sparks, or smoke happening in the magnet area. So we can cut down the power to the magnet room, and then we can allow the firefighters or anyone to enter after screening and taking extra precautions. Quench button can be pressed by the authorized person, but in order to bring this switch back, we have to call the engineers. We have to keep the control access area safe. The doors should be with access control with the keypad access or swipe access. Do not allow anybody unauthorized into this room. Do not share the access code with anyone as well. And also we have to thoroughly monitor the patients within this MR control area as well as in the examination room. And there should be clear communication between our patients. We have to provide them the emergency buzzer, and after 2-3 sequences, we have to communicate to them to make sure that they are not heated up and they're not having any further issues. In the case of emergency situations, we have to remove the patient from the scanner room, and the radiographers should secure the scanner room and should not allow any unauthorized emergency person to enter this magnet room. And if there is a need of sending them inside, we have to screen them and take extra precautions. And the cold white as well as cold blue, like cardiac emergency and clinical emergency, that should not be carried out inside the examination room. So we have to bring the patient outside to a resuscitation bay and perform this. And I would like to discuss about the safety aspects of intraoperative MRI or IMRI. The place where I'm working, we do intraoperative MRI. It's a specialized imaging technique used for surgery, especially for the neurosurgery, where we can get real-time imaging of the patient's head while the patient is still on the operating table. The benefits of IMRI are a better tumor resection, because the surgeon can assess the resection, and also we are giving them the contrast enhanced images intraoperatively, so they can provide real-time feedback to the surgeon, and they can decide the surgery, whether they need to proceed with the resection or to close the wound. Reduced risk of complications. As part of the intraoperative MRI, as a pre-scan, we are also doing the diffusion tractography as well as the functional MRI imaging, depends on the area of the lesion. So this is giving added information to the consultant or the surgeon, so they can safely resect the tumor without touching the complicated areas or the important areas of the brain. And since they are looking at the lesion intraoperatively, they can resect more lesions area, so that will avoid any need of further tumor resections. It also adds to the surgical precision, because they are getting a real-time image which is contrast enhanced as well, so they can see whether the lesions are enhancing. Also, we are acquiring a diffusion sequence, so they can see if there are any diffusion issues as well as any stroke, etc. during the surgery. The conditions commonly treated with intraoperative MRI are brain tumors like glioma, meningioma, craniopharyngioma, etc. It's also used for epilepsy, movement disorders, and vascular conditions like cavernomas and AVMs. We do the scans in 2 different days. The patient will get admitted in the hospital in the previous evening, and we do perform a preoperative imaging, which includes a T1 3D sequence. We do the pre and post contrast imaging of 3D. And also, this is used in the brain lab neuronavigation system. So we have to do this specific to the brain lab and without any angulations. We also like a T2 space sequence and a 3D flyer imaging as well. And we do a diffusion sequence along with this. Depends on the area of lesion. Preoperative, we do perform the fMRI, TTA fiber tractography, perfusion, and spectroscopy. And all this data will be available for the surgeon on the day of the surgery. So all this data will be loaded to the brain lab scanner, brain lab system, neuronavigation system. Intraoperatively, surgery, the surgeon will decide that I will stop surgery at this moment and I would like to see the images. So we will bring this patient back to the MRI room, and we will perform the sequences which we did in the previous evening, which are T1, T2 space, FLAIR 3D, and DWI. And these images will be reviewed by a radiologist along with the surgeon, and they will take a clinical decision whether to proceed with the surgery, or if they are happy, they can close the surgical wound. These are the equipments used in the intraoperative MRI. We use a magnet. In our case, we use a 3 Tesla magnet because, for advanced neuroimaging, a 3 Tesla will be always good. That increases the potential risks as well. And the table is a special table. This is not the actual MRI table. This table doesn't have the spine coil or the spine element on it. So this table can be docked with the theater table, and the top of the table can be slide onto this table, and we can bring the patient to the MRI room and dock it to the MRI machine. We can proceed with the scans. And on the right side, we can see the IMRI head holder. So we can see 3 spokes which will be connecting to the patient's head, that will secure the patient's head, and we can place the coils. They will be like 8-channel coils, one above and below. So intraoperatively, we are using these coils to take the pictures of the brain, whereas in the pre-op scans, we use the standard MRI coils. And at the bottom image, we can see there is a Norris gauge device used around this coil. Once you connect the coils, we need to make sure that this setup will fit inside the bore of the magnet, which is around 70 centimeter. So we have this gauge equivalent size of the magnetic bore. And then we can make sure that once we transfer this patient back to the MRI room, that patient will fit inside the room, the MRI portion. This is the diagram of a typical IMRI room. So we have the magnet. We can undock the table from here, and there are doors in between the theater room as well as the MRI room. Of course, they are the radio frequency doors, and we also have an extra added sliding door to the radio frequency door. And we will remove this patient, undock the table, and remove the table. Bring this here. This is the theater table, and the top of this theater table can be transferred to our MRI table, and we can bring the patient back to the MRI room. And on the top, we can see the neuro navigation system, which is used. All the data from the pre-surgical scans, tractography, fMRI, everything will be loaded to this system. This will be used for the registration purposes. So this is the IMRI. In the IMRI procedure, we have surgeons, the scrub team, anesthetic practitioners, anesthetists, physicists, radiographers, and a radiologist as well. So we meet up in the morning of the surgery in the pre-huddle, and we discuss about the case, and we will also discuss about who are all trained for performing this procedure. So we'll also give the MR screening form to all the people participating in the surgery. And also we'll make sure that they're all inducted or trained for the MRI safety, because safety is the more concerned about this safety, because we are directly bringing a patient from the theater table to the MRI room, and we should not leave any metallic objects or anything with the patient which will cause which will act as a projectile in the MRI room. So we have 3 checklists. In the pre-huddle, we will discuss about the first checklist. We'll make sure that the EGFR values are okay. Patient doesn't have any implant, which will be taken care in the previous MRI scan, because we will be going through a thorough screening form. And on the day of the scan, we'll also make sure that these doors are working. And also we will remind the anesthetist to use the non-reinforced ET tube for the procedure. And we'll also check whether they are planning to use any new equipments which we haven't used in the previous surgeries. And we will identify the team members. We'll make sure they're all trained. If there are any new team members, we'll bring them to the MRI room. We'll give them an induction before we start the procedure, and screening form will be done as well. On the right side, we can see the checklist for the physicist. The physicists are taking a leading role in the registration purpose. So they will be loading all the pre-scan images to the scanner. They will make sure that all the images are available for the surgeon. And also they handle the neuro navigation system. And also they have a checklist to make sure that all the equipment they used for the registration should go back to their respective boxes. They should not leave any items on the patient's table or the surgical table, which might go into the MRI room during the intraoperative scan. During the IMRI transfer, which is the intraoperative MRI transfer. We have more detailed checklist. So there is a checklist for the scrub team, making sure that they have checked the instrument count and they're all correct. They have returned all the instrument back to their trays. And we'll also make sure the neurophysiology team checked all their electrodes are back. And also there are checklists for the anesthetics team that they have taken out the warmer float on unit and any equipment they have used which are not MRI conditional, they have to remove from the patient. Sometimes there will be infusion pumps, and these infusion pumps are not conditional for the MRI, so we have a space station where the infusion pumps should go to, and they have specific locations in the fringe field. So we have marked the lines inside the MRI examination room where these particular equipments will stay. And also the anesthetist should make sure that they are using the normal endotracheal tube, not the reinforced tube. They'll be checked for the surgical teams that they have secured the wound, they have draped everything correctly, they have placed the earplugs because the patient is sedated at this stage. So we have to make sure that they have earplugs in place. And also we'll check with the surgeon whether they have used any Liga clips or any new implants in the patient in that particular surgery. Again, the radiographer will double check that patient is having the earplugs, and they will also make sure that none of the cables or looping is happening, and urinary catheter is removed, secured, and also reinforced ET tube is not used. And there will be checks for the neurophysiologists that team that they have removed all the electrodes. And again, the MR physics team has to make sure that the entire setup will fit inside the magnet bore, and they have to make sure that the coil connectors are accessible so that the radiographers can connect them inside the magnet room. And after going through a full checklist, we will get the signature from all these team members. So they are all responsible for what they have told in the the huddle. Then we will go ahead with the scan. After the scan, we will call the radiologist, and he will review the images with the surgeon, and they will take that clinical decision. And most of the cases, we will stop with one scan. And giving contrast depends on the nature of the lesion. Some lesions we don't give contrast, especially if it is an epilepsy case. But most of the other lesions which is enhancing, we will give contrast. The images will be verified by the radiologist, and they will have a discussion, and then we'll take the patient back to the MRI, the theater, neurotheater, and we will stop the scan. And after everything, we have a extensive list of cleaning for this coil. We have dedicated cleaning equipments as well as the liquids for these coils. And periodically, we do calibrate this coil as well. We have to send it to the company, get it calibrated. That's all from me. Any questions?
Thank you so much, Abhilash. So that was a really comprehensive and thought-provoking presentation. You painted a clear picture of MR safety as a culture, actually, not just a checklist. I was particularly fascinated by the intraoperative MRI that you've just explained in details. Truly fascinating, and I would love to be a quiet observer at some point in your center, if that's all right. So obviously we can catch up about that outside this if you're okay with that. So I can see a couple of hands being raised in the background. I do promise you guys that we will come back, but looking at time constraints, I'm just going to go back into our next speaker. But Abhilash, thank you very much for that. You explained the critical role of non-radiology staff training, and basically contributed very well to the MR Safety Week that we are trying to promote today. I think we can all agree that an environment where one lapse can have serious consequences, building a shared sense of responsibility across all disciplines is very, very important. So your emphasis, Abhilash, on clear communication and vigilance has really resonated. Thank you very much for that. Okay, so I'm just going to try and share my screen again. So for our final session today, we are joined by Noyal Mathew. very familiar face, I'm sure, for most of us. He's the Head of Education and Professional Development at PAIR, and he's the MR Education Lead at University College London Hospitals. He has 12 years of experience in radiography, out of which he has served as an applications specialist, an educator, and a radiographer. So Noel is an exceptional educator and a driving force behind many safety initiatives in MRI training. Tonight, he'll be focusing on implant safety updates and will also delve into the questions in an MRI safety questionnaire. Noel, the floor is yours.
Thank you, Afra. Thank you for those kind words. Just going to quickly share my slides. Can someone quickly confirm whether they can see my screen? Am I audible? Hello?
Yes, Noel, please.
Thank you. So I'm going to be talking today about something that's very familiar to all of us, which is the MRI Safety Questionnaire. And I'll try to shed some light on a few implant updates from my side. A little disclaimer, I'm not going to read through it, but just to be sure, all of you need to adhere to your institutional policies that you have in place. And this is not to override anything as such, but rather to give you a little idea as to what has changed probably over the last few years or the last few months in terms of MRI safety. So please do come back to me if you have a question towards the end. A few learning objectives. You will be able to understand the purpose and key components of the MRI safety screening questionnaire, obviously. We're not going to go through the entire questionnaire, but I've selectively chosen a few highly relevant questions that we can explore together. You will be able to recognize common pitfalls and best practices in MRI safety screening and discuss recent updates related to specific MRI conditional implants. And lastly, you will be able to apply practical decision-making strategies to ensure safe MRI practice. I beg your pardon, but can I also quickly check if my screen is frozen? Because when I started resharing, I'm not sure if... Could one of you quickly confirm if you can see me all right? Not really sure if you can see me, but I'm just going to continue and go forward for the benefit of time. So the rationale as to why we've chosen this topic and why it's relevant is because MRI happens to be functional based on a powerful magnetic unit with its add-on RF fields, and the risk of heating, torque, malfunction, displacement, and the list goes on and on. And patient safety is of paramount importance, therefore, also not to forget the fact that there might be issues relating to litigation and liability. Now, if I were to give you an overview of the questionnaire, we are quite accustomed to the questionnaire and all the questions, few of which happen to be relating to medical devices or implants, surgical history of the patient, occupational exposure to metals such as intraorbital foreign bodies. It could be shrapnel injuries, pregnancy or breastfeeding, the very popular tattoos and piercings question, and lastly, whether the patient has claustrophobia or anxiety. Now, these are some of the key questions, though, which often dreads us all as MRI radiographers, which is whether you have a battery-run device such as a pacemaker or an ICD, and the patient says yes. Or do you have any magnetic electronic implants in any part of your body? Have you ever had any surgery to your head, neck, spine, eyes, or ears? And if it comes up with a yes, then we are a bit not relaxed anymore, but we take a sense of caution from those questions. So let's delve further into pacemakers and ICDs. So pacemakers are active devices with a battery source, and they consist of a generator and at least one lead, which is obviously conductive, and it could go on to maybe more than one lead, and each constituent component needs to be checked for conditions. So it's not just the pacemaker device that's external, which is the pulse generator, but also the leads. All the components need to be checked for MRI conditions, and interrogation of the device is normally done before and after each scan with the pacemaker in situ, wherein an electrophysiologist assisted by a physics personnel or someone else will interrogate the device to make sure that it's in the appropriate mode, example an MRI safe mode, and then after the scan to put it back into the appropriate working condition. And one of the things that we need to be careful of as MRI radiographers is leadless pacemakers. So this is something contemporary. It's quite new in the market. So please don't be deceived into thinking that it's a loop recorder or something else. It looks quite similar in that it's a small, nice little device. Nevertheless, it is a leadless pacemaker. So let's have a look at some pictures. So we're all familiar at some point having seen a picture like this, wherein you've got the pacemaker that either sits on the left or the right side of the heart, mostly on the left side. And we've got the sternotomy, the rings followed by, we've got different leads going into the atria and also the ventricular electrodes, which are very typical for a pacemaker. Now, this second example here, if you can see it, is an example of the leadless pacemaker. So it's quite situated towards the mid heart or towards the apex, and it is cringing onto the heart. It doesn't have any kind of lead. So please make it a practice to go through the patient's previous imaging, including chest x-rays and scouts. And if you were to think what differentiates a pacemaker and an ICD, this is an example of how the pacemaker looks like, which is just a pulse generator and leads. Whereas the ICD looks quite similar, except that it's got these hard coil-like bits as well to give the shock to the heart if need be. So that's an indicator of whether it's a pacemaker or an ICD, and the ICD will have a thicker one. Let's move to cardiac monitors. So we have different kinds of monitors. We're all accustomed to doing this. We regularly come across some Medtronic devices in the form of Reveal Link devices and so on. So these are very, how do I say, these are very easy to scan, or rather safe to scan, or if I were to be a bit more, in safer terms, I would say conditionally okay. And there's only one model, which is 1.5T conditional only, which you need to familiarize yourself with. So not every loop recorder is conditional or okay to be scanned. There is one that's evasive, and you need to make sure that whether that's the model, which is not food for thought today. And if you come across the Holter monitor, also known as a 24-hour or 72-hour tape, that is MRI unsafe. It cannot be permitted and cannot be confused with a loop recorder or some kind of an ICM. And Zeo patch is also one of the variants, which is, if I were to show you the picture, this is what a loop recorder would look like on a chest x-ray. No leads, just a device shaped like a battery, like an alkaline battery. And the second one here shows you what a Zeo patch looks like. It looks typically like a miniature cassette from the previous eras with two little circular things, and it's a patch like how the name indicates, and it has to be removed as well before you send the patient inside. Coming to shunts, shunts are devices that enable people with hydrocephalus or some kind of obstruction in their ventricles to better drain their ventricles, and that their cerebral ventricles or subarachnoid space can free itself of that extra CSF, which is diverted into some part of their body, mostly the peritoneal or the thoracic cavity, by means of small catheters. Now we have different varieties of shunts. We have fixed pressure valves, also known as non-programmable, gravitational valves, which means it's just flowing based on gravity. And lastly, we have programmable shunts, which are also described as adjustable shunts. Now, the non-programmable ones are mostly okay to scan, and the conditions are less restrictive. But the programmable shunts are those where the MRI conditions need to be strictly followed, considering some of them still need an X-ray to be taken before and after to check the position of that appropriate the shunt device. Now, and also the valve settings might change, and that's the reason why we need to know how it looked pre-scan and post-scan. With the exception of a newer device which Medke produces, which does not really need pre and post check. So if you come across an MRI programmable shunt that's manufactured by Medk, you can go to the website and counter check for yourself, but it's okay to scan immediately after insertion, and it doesn't need a check, and it doesn't need any kind of intervention. And this is what a shunt looks like what I explained. And this is how we normally check the X-ray for the valve settings. And what mentioning that the X-ray needs to be hitting perpendicular to that valve, and it's not just a random lateral or AP X-ray. So if you ever request an X-ray, and if you're working at the NHS, please make sure you advise your X-ray colleagues to hit it on the valve so that you see it in a clock-like fashion. And this is what the Medk ProGav 2 device looks like, which does not need adjustment, considering the fact that it can adjust by itself. And please try to scan these patients by just counter checking on the website. Do not send them back. Cardiac stents and valves, coronary stents are all fine, at least for now. If you have at the NHS or in different trusts where we work, if it's up to 2 or 3 stents, we normally go forward and do the scan. If it's more than 3 scans, there's a small potential that they have kind of lined up with each other to form one big conductive piece, which can then cause problems for the patient. So up to 2 or maybe even 3 are normally fine, but if it goes above that mark, we're checking where these stents are situated. And heart valves are made up of 2 kinds of components. One is a metallic type, which is mechanical, and the other one is an organic heart, which is either made of bovine or porcine content, which is from pigs and cattle, and which are safe to scan. Of course, the metallic bits that harbor these are metallic, but the device as such is MRI safe if it's made of organic content. PFO closure devices are patent foramen closure devices such as implants and so on. So these normally have to be checked for conditions, but are conditionally okay, provided you know what the conditions are. So do not assume that anything that's safe on 3T is safe on 1.5 and vice versa. It can have specific conditions, including for atrial appendage clips. And this is just an example of a triple valve replacement to show you how a valve would look like on an X-ray, which is just a circular little piece. And that's how it looks like on an X-ray. Going on to neurostimulators, quite a lot of patients coming in these days with these devices, and this is an umbrella term for a variety of devices that includes deep brain stimulators, spinal cord stimulators, sacral nerve stimulators. So if you look at a deep brain stimulator, this is what it looks like. You've got a device that looks something like a pacemaker, sending a lead all the way, a connecting wire terminating in an electrode all the way to the brain, and the patient normally activates it. And this is an example of a spinal cord stimulator situated somewhere near the sacrum, for example, or a sacral nerve stimulator quite specific to the sacral area in order to stimulate the lower bits, including the ones that enables them to go to the toilet. Vagus nerve stimulators are situated quite above the pectoralis muscle, considering the vagus nerve is running in your carotid territory. Of course, it goes down, but then that's the region they are looking for. So these are ways how you can differentiate and identify what kind of stimulator it is, depending on the location. And lastly, we've got the cochlear implant, which is obviously going and terminating into the cochlea, which is inside your ears. So all these devices have batteries and leads, and they have a charger and a controller, which is completely MRI unsafe. You cannot permit that, which is normally patient held, which is the controller device like a phone, and the charger. And this is what it looks like. So the device is that which is sighted on the patient. The leads are sometimes not visible, considering they go into the body. The remote control and charging cannot be permitted into the room at any point of time. The device as such is MRI conditional as long as you've gone to the website and had a look. Most of the devices these days are conditional in that they allow us to scan freely depending on which area you're scanning, whether it's above T1 or whether it's between T1 and L5 and so on. So you need to understand what you're scanning and whether those conditions would fit in. Please do not send them in immediately. And the risks that are involved are projectile, unintended stimulation, device malfunction, and of course, heating, like what my colleague said. Moving on to cochlear implants. Now, this signifies, the name signifies what the device is, so I'm not going to go into what it actually is, but just so you know, there's a risk of patient injury. It is an active device, and there's damage of function. And the patient can be in a lot of pain if you haven't scanned this appropriately. This is how a cochlear implant looks like. So it's got an external component which also has a magnet. The internal component is also a magnet which is fixed inside the skull. And there is a connecting wire that takes this all the way, bypassing a variety of structures inside the ear all the way into the cochlea, thereby you get maximum benefit out of it. Now, some of these are conditional. Strict safety conditions need to be met, and of course your pictures will be surely artifactual. Mostly it is the physicist who helps with these kinds of scans, but there are MRI cochlear implants that can be scanned without you needing to remove the internal magnet or without you needing to secure it in place with a certain tape. So please go back and check Cochlear, which is the company that makes most of these implants, or Bionics, to make sure whether that model is one of these. Now, this is how the picture would look like. If you did scan with the implant magnet in place, you can see pretty much the entire area is obliterated. And if the implant magnet was removed and safety precautions with the tape was done, you can restrict the signal void to a certain centimeter limit, thereby reducing artifacts. So this is an example of one of those newer cochlear implants. If I'm not mistaken, I think it's produced by Bionics Group, and it's called the Ultra Advanced HD. I could be a bit wrong with the nomenclature, but the beauty of this device is it's got a bipolar magnet that keeps circulating depending on the position of the patient, and thereby you don't have to secure it with an adhesive tape or the tape that comes along with the kit. Moving over to Baha. So this is called as a bone-anchored hearing aid. This is not to be confused with a cochlear implant. It could be one of those umbrella things that fall into either and has an overlap into each other's territory, but this is completely different because it is anchored into the bone, and it doesn't have a lead or a connecting wire going into the cochlea, but rather it's bypassing the middle ear cavity so that signals can go via the bone and then thereby go into the parts of the ear where the processing takes place. So it has two parts as well, which is the external component. As you can see here, there's a device. It's got an abutment which has a little bit of metal, and the third bit which is actually going into the bore, which is boring into the bone actually. And there are two kinds of Bahas. I remember someone putting it on one of our groups. So please don't assume that all Baha devices are conditional or safe to scan immediately. You will need to check what kind of Baha device it is. If it's an Attract system, this is, by the way, the external component. The Attract system has a sound processor and an SP magnet and must be removed before entering the room. And it's only possible for you to scan it on 1.5T, whereas the Connect system, which looks something like this, can be scanned on a 1.5T and a 3T conditionally. Whereas the Attract system, as the name signifies, has a magnet, and therefore the magnet and the processor need to be removed, and this is only done on a 1.5T. So please go back to Cochlear's website and check which one of these Bahas you've got in front of you before you commence your scan. Moving over to IVC filters. So this is for the inferior vena cava to prevent thrombus from reaching different areas of the body. It is mostly made up of an alloy which is called as alloy or Phinox. What it actually comprises is nickel, chromium, and cobalt. And thereby, because it's an alloy, these metals are notorious when they are differently or separately in their original forms, but as an alloy, they tend to be more compatible to the body. And the spontaneous migration rate is very less, to be honest. It's just about 1% or less. So there's no clinical evidence to say why you can't do a scan immediately, but it's only wise for us to still wait for 6 to 8 weeks for the simple reason that you want it to fibrose and stick to the vessel walls and mitigate even that small chance of migration. So as an institution, we just play it a bit safe here where I work, and we give it a 6 to 8 week wait, unless it's explicitly mentioned in the conditions that you can scan immediately. Moving over to another important thing, which is a diabetic monitor. We come across these devices very frequently these days. The third one is my favorite because I see it all the time. It's the Freestyle Libre model. And this model is, as of now, the MHRA in the UK has not given us the flag to say you can scan these conditionally, but it has been FDA approved in the US, and it can be scanned MRI conditionally. You don't have to remove it in the US, but I think for us now in the UK, we still need to remove these devices before we send them in, considering it's got that tiny metallic thing. There's only one diabetes monitor that's completely MRI conditional, and that's the Eversense system. It looks like this. It's got a chip inside the body. and it's got an external transmitter. So as long as you remove the external transmitter, the internal chip is okay to be scanned. Transdermal medication patches. So the reason why we don't want these patches now, it's one reason is because these patches have a metallic coating within them, so that they can be antimicrobial, or so that they can, stick to the patient's body better and so on. So we don't want that aluminum or silver layer to heat up the patient. And the second also being that the RF from the MRI can lead to it inadvertently releasing more drug than it needs to, or making it release less drug than it needs to. So let's say if a patient had a fentanyl patch, it could lead to over release, or if a patient with a menopausal lady with a hormonal patch could have more hormones being given into the patient depending on their body heat increase, thereby causing them to have sensitive body parts like sensitive nipples and so on. So that's the reason why we ask them to remove this. Now, why do we ask patients to remove clothing with magnetic components? I think one of my fellow speakers have just mentioned the significance of you needing to remove, considering it's got tiny metallic fibers in it. So one of the recent examples is the Lululemon sportswear, which comes with some kind of a metal backing inside, which is sweat resistant and antimicrobial in that it has something to do with silver, if I'm right, and therefore that can lead to we heating up our patients more than we need to. So please ask your patients to remove their sportswear, and in fact remove all their clothing, and if you can get them into the gown, that's optimal. But I know logistically it's a bit challenging, but please make sure you check with the patient, especially when they come in during winter time, if they're wearing one of these Lululemon sportswear. Another one is period pants and colored contact lenses, considering they have metallic salts in them as well. Now, the last thing what I wanted to mention was the magnetic resonance output conditioning. This is an update that's come through via the British Institute of Radiology, and what we need to it's a way of saying that you can the horizon is looking more bright, and that we can scan more implants in a more sensible and a better approach. So it works alongside existing controls like SAR, and it allows the operator to select the appropriate RF coil, the transmit the polarization mode, whether it's CP mode or transmit mode or multi-channel. And also it helps you to maximum utilize the B1 RMS values. You can customize it. You can enter it into a value that's flagged as correct according to the website, and also you can limit the machine's maximum gradient slow rate so that you don't have to worry about it, but the machine itself will make sure that it kind of fits into that umbrella of parameters. So this is something that the MHRA, I believe, is working with all the vendors, in fact, in the UK, to make sure that they get it done within 3 years, according to this white paper that the BIR has just introduced, which would make implant scanning quite easy for us, and it's looking bright. So just to conclude my slides, every question on the safety questionnaire deserves credit, and it is there for a reason, and it serves a critical purpose. So please don't underestimate something only on the backing that you've had many of these questions and no one answered yes to these in like a year's time. It could be that person coming on the 366th day who has answered yes. So please do not let your guard down. Understand the whys behind these questions so that you can explain to the patient in case they ask, why do I have to do this every now and then? I've come here like 10 times and you make me do the whole thing again and again. So you need to be able to answer their questions and be especially vigilant with implants, devices, and conditions that may not be obvious to the patients, like ICMs, like your Link Medtronic device or Baha's or neurostimulators, which they had. Highly unlikely that they're not going to know about it, but in case they forget about it, especially if the patient's not compos mentis, you need to negotiate, and you need to talk with a referring doctor to make sure how this scan is going to be done. So please be vigilant. When in doubt, please pause, verify, and escalate. And as MRI professionals, as I say, you're the first line of defense and safety. So it's you as radiographers and physicists and all of us who do this work, and we need to do this together. Some references. I've basically compiled everything from different websites and manufacturers, and thank you so much for your time. If you think you have any questions that I can't answer, please do connect with me and let's have a chat. You can always connect with me on LinkedIn, and I try to be active on social media, so that's my QR code if you want to connect with me. Otherwise, thank you so much for your patience, and happy MRI Safety Week. Thank you all.
Thank you so much, Noel. That was such an insightful session. You reminded us that MRI safety questionnaires isn't just a form, is it? It's actually a patient's story. I also appreciated your discussion on conditionality confusion, especially the risk of assuming that things are MRI safe when actually many devices are only conditionally safe under very specific conditions. Your talk definitely reinforces the idea that we must slow down when it matters the most, especially during screening, and that every yes or not sure responses deserves a full investigation. Thank you very much for that, Noel. So that brings us to the end of today's Speakers Corner, and the stage is now open for questions for a couple of minutes. I think I did see one of the questions in the chat earlier, which would have been for Abhilash. So the question is, if we press the stop button due to fire hazard, does MR lose magnetic field? And that is from Saeed Nizamuddin. Abhilash.
Can you hear me?
Yeah.
So when we press that stop button, not the quench button, the other button which I mentioned, that will only cut off the electricity to the equipments in the scanner room. But the mechanism for the cold head and the other areas which produce that superconductivity is separate. It doesn't quench the magnet.
Hope that
So when you
answers.
press the quench button, then it triggers the quenching.
Yeah. Thank you very much for that. Another question from Pavan Kumar Harish, and I suppose this would be for Noel. Is there a website where we can check implant details? We need to verify the model and manufacturer to determine whether the implant is MR conditional or off-label. Could you please share the appropriate sites for checking this information?
So this is one of my personal favorites. Quick answer, the best place to check for MRI conditions is the manufacturer's website itself, for the simple reason that our American counterparts in MRI Safety might have not updated their websites with the likes of, different websites that we have. So please check the manufacturer's website, because that's where the conditions are updated on a yearly basis or whenever they run their checks. So something that was unsafe could have become conditional over time. So I think it's only sensible for us to check that and keep that as the first result. If you can't find something, you can always go to one of those websites, such as MRI Safety, for example, and have a quick look. And yeah, and regarding off-label scanning, I'm not really sure if I have understood this. So off-label would be if you do not have any conditions on the manufacturer's website, then that would count as off-label scanning. Not that you can't do it, but I think it's something that needs risk assessment. You need to sit down with your physicist, try to see the rationale behind the scan, come up with a protocol regime, and do it in a controlled way. So that is possible and doable, provided you have some kind of support. And if you can't find information on the manufacturer's website. So there's no one-stop solution for checking information. Another reliable source would be for you to email the doctor if you need to know the make and model of what's in there. You need to get in touch with a referring clinician, and you can always make use of EPR or EPIC or whatever system you use to get up-to-date implant data.
Fabulous, thank you. Next question from Srinath Srikumar. Question to Abhilash about resonance circuitry. Please explain the length of leads. Sorry, Abhilash, you're muted.
Okay, so they want to know the resonance circuitry, the length of the leads.
Yep.
Okay, so basically, I did attend a session with the Dr. Kanal's course, and he brought this topic, resonance heating, and it was new knowledge for me as well. And we always think that when we move from low strength to a high strength magnet, all these hazards and issues will be increasing. But he did explain me about a situation where it was an example. It was a real story. It was a hunter. The patient was a hunter, and the patient had a deep brain stimulator implanted, and this implant length was over at 35 centimeter, and thinking that it will be safe on a one Tesla scanner, this patient was taken into a 1 Tesla scanner. That led to resonant heating, and there was like a heating inside this patient's brain. So the length comes from the resonance frequency of each magnet. For a 3 Tesla, it's 128 resonance frequency. So its wavelength will be in the range of like, I'll say 25-ish. Then half of that value is 12. That's meant for the 3 Tesla scanner. And it can heat above and below 12, but maximum heating will be in that length. And for a 1.5 Tesla, which is half of it, so this 12 will become around 25. And a 1 Tesla, which is 3 times 3 Tesla length, so which will be around 35-36 centimeters. So it is applicable for the insulated leads, because lead is insulated, which is inside the body in x-axis of the magnet. That's the condition. It should be in the x-axis, like in the line of the patient's body, and both ends are touching the skin. That will cause the skin burn.
Thank you very much for that. Next question is from Jay Lee. How can we ensure the safety of bariatric patients from skin burns? Suppose that might be either for yourself, Abhilash, or for Shilpa. Abhilash, did you want to go ahead to answer that? Safety of bariatric patients from skin burns?
Safety of bariatric patients. Basically, we have to keep the side pads inside the bore, which will avoid the skin touching the patient's skin touching the bore of the magnet. As I explained, 1 centimeter within the bore of the magnet is called the danger zone by Dr. Emmanuel Canal, because in that area, even though manufacturer can make a 69 centimeter bore magnet instead of 70 centimeter bore to avoid that 1 centimeter gap. The spacers, they are not actually, if you touch the bore of the magnet, it doesn't heat your arm. The radio frequency, which is causing the heating, that will be more within that 1 centimeter range. If you keep a spacer there, then that will avoid this heating effect.
Absolutely.
Did
Thank you
I
very
answer
much.
the question? Or
I think you have. I
okay.
think you have. There are a couple of other
And
questions.
also, in case of bariatric patients,
Yeah.
fat doesn't have much of the heat sensors. So once you start heating this patient's fat, the patient will only come to know when this reaches, after burning, it reaches the subcutaneous level where the heat sensors are more. So by that time, it might have done its work, like it might have heated the entire fat. And after a few days, it will appear on the skin, and that will cause the 2nd or 3rd degree burns.
Right, thank you. I think we've got another question for Noel. Is it normal to ask questions about CGM on pre-booking MRI safety checks?
Sorry, could you repeat that question again, Afra?
Yeah, so is it normal to ask questions about CGM on pre-booking MRI safety checks?
I would suppose so. I think considering there's a burgeoning population that's got diabetes, I think continuous glucose monitoring is almost there. If you look at 10 people, I think I wouldn't be wrong if I said at least 2 would have a CGM. Or pardon me for that overstatement there, but I think it should be a part just so we know that they have a CGM and that there's a variety of CGMs available on the market. At least the ones that are being promoted by the NHS are the Freestyle, Libra 2, 3, and so on ones, which are sold by Abbott. So these devices, as of now, are anyway, we ask the patients to take them off before the scan, and it's so unfair because the patient has just fixed it the morning of the scan, and it is a costly device, and some of which are purchased by the patient themselves. So I think it's only fair for us to include it as a pre-screening, or even if you were to fix appointments with the patient beforehand, I think it's a question we need to ask them. Do you have one of these? And if you do, would you mind, deferring it until the scan is done? I think that would be a good approach. Yes, for sure.
Fabulous.
And
Thank you. Yeah, did you want to add anything more, Noel?
there's another question I thought I'll just finish off.
Yeah, go on.
There's a question about, can you share any details about IVC filters, and is that similar to vessel stents? So in terms of appearance, no. The stent is more like a scaffold, which looks more tubular, whereas the IVC filter looks more like an umbrella, considering it the reason why you have it is to stop something. So the way how it works is like a funnel. So it's got a mountainous appearance in that it wouldn't let the thrombus pass through it, but kind of keeps it in place. So That's the first bit to the question. And in terms of properties, the materials that go into making a stent is usually platinum, or it could be a certain category of stainless steel, which they call as 316L stainless steel. So it's a little bit different in that it needs to expand the artery in which it's going to be sited, or at least stay there. So the material is a little bit different, whereas the IVC filter is normally made up of something called as Finox or Elgiloy, which is a more stubborn and strong alloy made up of nickel, chromium, and cobalt. So there is a little bit of difference, and even appearance-wise, they look a bit different. So I would urge you to go back and check your X-rays. They look quite nice and clear on X-rays if you can check, or on CT scouts. So it's something you can't miss. So I hope I answered that question.
That's fabulous, Noel. Thank you very much. We've got some really, really relevant questions in the chat, but due to time constraints, I'm just going to, wind up here. However, please can I request our speakers, if you could kindly take a moment to reply to them over the chat tonight, that would be really appreciated. So I want to thank all of you, our attendees, for joining us in honoring MR Safety Week 2025. Your presence and engagement tonight truly reflect a deep commitment to patient safety and professional excellence. A special thank you to our speakers, Shilpa Singh, Abhilash, Rajan, and Noyal Mathew, for generously sharing your expertise and practical advice. MRI safety continues to evolve, and it's staying current is not an option anymore. It is our professional responsibility. As you guys can see on the screen, I have shared a QR code where if you guys could please access the feedback form and complete it, let us know your reviews about today's session. And also that will be a platform to provide us with your details so that we can provide you with certificates for attending today's sessions, as well as probably some useful links to resources and any updates on upcoming PAIR CPD events. All right, so on behalf of PAIR UK, thank you again, and let's continue to champion MRI safety, not just this week, but every single day. Take care, stay safe, and have a wonderful evening, everyone. Goodbye.
Thank you. Bye.
Thank you, and
Thanks.
you too.